Hello, everyone, and thank you very much for joining our webinar on the management of neovascular macular degeneration. Together with my co-chair, Professor Frank Holz, we have a wonderful agenda. I have to admit that most of it was thought of by Professor Holz, who is going to be a little different than what is usually discussed on webinars on neovascular macular degeneration. And I'm sure that everyone, including me, will learn a lot from this webinar. We have wonderful speakers from all over Europe, and we'll have some time for questions. Please submit them on the Q&A, and we'll have some time to answer questions after each presentation, and also at the end of the presentations. So please join us and enjoy the new developments that we will expose here. So without further ado, I will invite Professor Rosa Dolz Marco to give us some surgical pearls and the clinical impact of the PDS in patients with neovascular macular degeneration, a very, very hot topic nowadays. Rosa, thank you so much for joining us, and please go ahead.
Thank you so much, Professor Loewenstein and Professor Holz, because I'm really glad to be here with you today. And I think as retina specialists, we are really living a great era because we have in the pipeline a lot of new molecules and new targets, also new ways of delivering the drug. We will see in a few minutes. And I invite anyone really interested in these new developments to review this Retina Today review on the pipeline. It's always every year updated by Dr. Kaiser. And I think it's really a good document to review, also available on geographic atrophy. One of the things that we encounter in clinic, in real life, is that we know that monthly intravitreal injections and monthly follow-up is the best we can do for our patients, is that where we can achieve the highest visual acuity. But it's true that we are seeking for other ways or other regimens, PRN, pro-Renata regimen, also fix every other month regimen, or treat and extend, which is maybe the most used or widespread. But there are other ways we can really improve the quality of our patients. And right now, the pipeline is filled with really sustained release drug deliveries, either because we use polymer-based drugs, so we use non-bioerodible or bioerodible implants, but also because we can use not only the intravitreal approach, but also other routes like the suprachoroidal approach with different kinds of cannulas or microneedles. And also because we can have gene therapy platforms that can really produce the VEGF suppression. But we are going to talk about another way of delivering the drug, which is a reservoir, and this is the port delivery system. And why this is important? Because we know, as I mentioned, that monthly injections is where we achieve the best approach. With pivotal trials, we knew that visual acuity is really good with these monthly injections, but it's not really achievable in daily real life. If we increase the period between injections, we may have decrease in the amount of anti-VEGF available in the vitreous, so might not be sufficient for some patients. So it's a good option for some patients, but not for everyone. So what PDS can provide is a sustained delivery of the drug, because we have a reservoir implanted in the pars plana, and we injected a special formulation of ranibizumab, and we can release this constantly. So we can achieve a good amount of drug in the vitreous. What we have seen by the data from the pivotal trials, Archway, and later the extension portal, is that with PDS, with this port delivery system with ranibizumab, a special form of ranibizumab, we can really have good options. So it was compared against intravitreal injection of ranibizumab, monthly intravitreal injection, and we can see that the visual acuity is really stable over time, so comparable. Of course, we cannot achieve superiority. We are just saying that it's equal to monthly intravitreal injections, and also the anatomy is really equal. And both those patients that were implanted the PDS after all the archway trial, so in the extension, in the portal, they also showed this stability of the anatomy and the function. So also it's true that the vast majority of patients, they didn't really require additional treatment, intravitreal treatment. So that's giving the idea that it's really capable of this sustained delivery of drug. And what's the port delivery system? So this is really another option. So we implant a device in the pars plana through a surgery that we will see in a few minutes. And that contains a special formulation of ranibizumab with 100 milligrams per milliliter. We have to do the implantation in the operating room, but the good thing is that we can do the refill and exchange of the drug every 6 to 9 months, so 1 or 2 refills per year in office. So there's no need to do it in the OR. We can do it in the office. And we will see. This is the view. So this is the tip when the patient is with the gaze looking up and temporal. If you look straight, you don't see the tip, the device. And this will be the device covered by the conjunctiva located in the supratemporal quadrant of the eye. And the size is about the size of rice, so it's really small, but still we are not really used to having these kind of devices within the eye. The procedure of the surgery is not really complicated per se, but has a lot of critical steps. So we have to be really detailed in the and we have to take care of all these details. So first we start with a peritomy, and as retina specialists, normally we don't really care that much about conjunctiva and tenons, but for this type of procedure, we need to be really careful with the peritomy and use special forceps, non-tooth forceps, and really have a good tissue, because at the end we have to really close the peritomy, and we need to have conjunctiva and tenons in perfect state. So we have to be really careful. Then we prepare the implant. We fill it with a special formulation of ranibizumab, and then we move back to the eye and do the scleral dissection. It's 3.5 millimeters in length. And this should be really exact, because at the beginning with the first patients that were implanted with PDS, they allowed to have like between 3.5 and 3.7, and that led to a little bit increase of some implant dislocation. So we have to ensure that this size is maintained. Then we do a laser ablation of the pars plana in order to decrease the risk of vitreous hemorrhage. Then we go for the pars plana incision, and then implant the insertion, and then the closure, which is really also really important. So we're going to see a video. It's really fast. So it's not that we can do it that fast, but peritomy 6 by 6 millimeters in the superior quadrant. Then we do the scleroid dissection with 3.5 millimeters. We have to measure several times. We do laser ablation of the pars plana, several rows. Then we measure again to be sure that it's not increased. Then we do the pars plana incision, and we insert the implant, and we carefully close with some overlap of the limbus and really tight tension and suture with some scleral bite. So we ensure that these conjunctiva and tenons, it's going to be there and protect our device. We are going to see also another video, which is a little bit older. And you can see that there's some conjunctival skirt here. The surgeon is also touching the edges of the sclera with some tooth forceps. And although the surgery looks really similar, and maybe this patient is doing beautiful, what Roche has been doing is reviewing all the videos of the implants that have been performed, okay, during the trials. And this has led to a lot of knowledge over time. So, for example, as I mentioned before, they allowed it to do 3.5 or 3.7 millimeters of scleral incision. Now we know it's 3.5, and with that, we have decreased the amount of vitreous hemorrhage and dislocation of the implant. Also, the laser ablation, it's important to decrease the amount of vitreous hemorrhage. This is the incision, should be 3.5 and square edges, not tilted. The precise handling of the conjunctiva and tenons also, it's really important. And we should think that we are doing like a glaucoma surgery. They take a lot of care of conjunctiva and tenons, so it's the same, okay, here. And at the end, they also changed the instructions for use for the refill procedure. So no twisting or maneuver of the needle is allowed now. So you decrease the force that you implement through the implant, because you know that they had a recall of the implant for some time. Now it's relaunched, and they changed the surface between the septum and the overmold. So it's now strong, the junction between both. And also they lubricated the needles. So it's really, they decrease a lot the force that you really do through the refill. And also they created this EVP rule. So you have to really be comfortable in your environment, depending on the chair you have, where you perform the refill. You need really good visualization. They provide you with a magnifier with light. And also it's really important to be completely perpendicular to the implant. So we ensure that we are really targeting the septum. The difference between doing a refill exchange and a normal intravitreal injection is that in an intravitreal injection, you have to be sure that you are in the pars plana, but you don't have a target. But with the PDS and the refill exchange, you have the target, which is the septum, which is really a small size. This is just an animation of how the refill exchange procedure is performed. Sorry. Can you click on the video? Because, yeah, thank you. So if you target the septum, then it's a double septum needle, so a double lumen needle, sorry. So you inject the drug and you also extract the old drug. So you put in the device fold the volume of the volume that you have in the device. So you inject 0.1, and in fact you have a fifth of that in the device. So you ensure that all the new drug is there, and you take out the old drug. And with that, all these changes and the careful follow of all these small details, they have decreased the amount of complications over time with the different trials and different indications. I just want to highlight these because I think they did a lot of effort. This is a picture with my colleagues, but also 2 of them are Roche employees that they come to every visit where you have to do a refill. They are with you when you do the implantation of the PDS. And I think that gives you a lot of confidence that you are doing really a good job. And the other really important point is that with the PDS, and especially in neovascular AMD, patients are super happy because they prefer PDS over intravitreal injections. I didn't mention, but before implanting PDS, you have to be sure that the patient is responsive to ranibizumab. So they already experience injections, and sometimes the fellow eye is also affected, so they are receiving injections, and still over 90% they really prefer PDS over intravitreal injections. And this is good news because PDS now it's available with ranibizumab, but in the future maybe we have it with other drugs like cefivancimig, which is a dual inhibitor of Ang2 and VEGF, like Vabysmo. So it's really good option because it's not what they call not PDS anymore, but port delivery platform, because it's more like something that you can use with different drugs. So I think it's really a change in the way that we can really treat our patients with neovascular AMD. We can achieve a really good control because we have a sustained release of treatment of drug. We reduce the burden of monthly or really frequent injections. So the selection of patients is also important, and we can achieve a really good satisfaction of our patients. So I think it's really good options, and I really encourage you to really try it. Thank you so much.
Rosa, that was amazing. Thank you very much. It was a great explanation, and I think we all look forward to start and use the PDS on our patients. Maybe just a small question: Are you planning to use it on all your patients with AMD? And now, by the way, there are the results of the DME, and also very promising. So, is this treatment suitable to all our patients, or just to frequent flyers, or what will be your routine?
Yeah, so that's a really good question. I don't think it's really an option for every case. It's not really needed, but those that really require super frequent injections, and we know we have these patients that we can really extend, I think that will be a perfect option because especially also those that have really a lot of anxiety with intravitreal injections might be also might benefit of this option, completely different. So yeah, frequent injections and patients that really don't want to talk about any needle because the refill, the feeling is not the same as compared to an intravitreal injection. You are not really going through the sclera, and so that makes a lot of difference in the feeling that the patient has. So that's also a good option. But with these drugs that now we can extend and treat every 12, 16 weeks, of course, those patients will benefit like with 3 injections over the year. Maybe it's not an option for them.
Thank you. Maybe a brief question from my side, Rosa. Brilliant presentation. Thank you so much. So you have vast experience with the surgical implantation, obviously, and Anat addressed the question of patient selection. I was wondering surgically how you select your patients. You mentioned that conjunctiva is important to be strong enough to have no retraction, no hole formation.
Yeah.
So is age an issue, and how do you assess the conjunctiva?
That's really a good question because, in fact, they advise you to touch the conjunctiva with a cotton tip and things like that. I mean, I don't think you really, with a cotton tip in the clinic, you cannot really know how is a conjunctiva. So maybe we lack a little bit of information before the surgery. It's true that I've been quite lucky because our patients are now beautiful. I don't have a patient with erosion or thinning of the conjunctiva, and neither fibrotic scarring, which is also like the opposite, but it's not good because you don't see the target, the septum. So they are doing well. You have to avoid patients that have been treated with IOP, so glaucoma patients and all surgeries that may touch the conjunctiva. But yeah, and check that the supratemporal quadrant looks good.
Mm-hmm. Thank you so much, Rosa. We will come back
Thank
at
you.
the end for the general discussion. And now it's
Sure.
a great pleasure to call on the virtual stage, if you will, Professor Tunde Peto and Dr. Lajos, both renowned experts in the field of retina and imaging, obviously. And they just recently published a really landmark paper, which I liked really a lot, on imaging modalities for fibrosis in neovascular AMD, sort of a neglected feature in neovascular AMD, and I'm very much looking forward to their talk on fibrosis in neovascular AMD. Tunde.
Thank you very much.
So, there were many questions in the Q&A. We will get back to them in the final discussion. So stay tuned. Sorry, Anna.
So thank you very much. So I'm going to start with just something that we probably don't see very often. So this is one of our patients with diabetes, and of course we know that with diabetes people attend screening very regularly, and so usually we don't have more than a year between imaging, even if they don't come more often. So this patient had no problems with their vision and was attending the optometrist as well. So this is the previous screening, and then of course a year later the patient came back and suddenly this was the picture. So this is something that my generation would have seen a lot. My generation of ophthalmologists. This is a very large fibrovascular scar, and this is what we don't really see anymore very frequently in our clinics, because the fibrosis have really changed its characteristics, and it's not the big one that we used to see. It doesn't take all the vision away, but it doesn't mean that it's not an issue. And we do know from epidemiological studies that fibrosis and sort of its related issues with visual loss are still a problem. So I'm going to hand it over to Dr. Chinchik, who has very expertly led the group together with all the co-workers to get the fibrosis paper and the fibrosis work that we are going to be talking about. So thank you very much. And Lajos, the floor is yours.
Thank you, Tunde, and thank you for the invitation. I'm very excited to talk today about two of our recent projects. One of them is the fibrosis agreement study, which Tunde mentioned as well. It's just published our results in the American Journal of Ophthalmology. And the other one is just kicking off, and it's basically built on the results of this project, which I'm going to talk about later. So first, I'm going to talk about the fibrosis agreements, and why we undertook this study. So we know that the prevalence and incidence of subretinal fibrosis in exudative AMD shows considerable heterogeneity. That could be due to the inconsistent definitions for fibrosis, but also the use of different imaging modality in different studies reporting prevalence and incidence. But we're not aware of any studies assessing this latter one. So this is what we done in this study. And what we did, basically, we looked at AMFAS imaging modalities, color fundus images, and fluorescent angiograms. The current imaging modality to detect fibrosis is the color fundus images, and we wanted to see how they perform compared to detecting fibrosis or AGRAM that corresponds to fibrosis on OCT. So where did we get our data? we extracted data from the EDNA study. This is the early detection of neovascular age-related macular degeneration study. In this study, participants were enrolled at detection of NAMD in the first eye and monitored for exudation in the second eye. Now we subset 130 participants from the EDNA study with multimodal image sets and corresponding clinical data. We made sure that the visits we get the images from and the clinical data are at least apart from 12 months apart from the treatment initiation visit. And then we graded for the presence and absence of fibrosis or AGRM on OCT using predefined criteria, which I'm going to show you in a second. And we further graded or further characterized AGRM on OCT based on its location. We classified to sub-RP and sub-retinal, and we also measured its dimension. And in terms of definition, what we used were for color fundus images, well-defined regions of white, yellow, or grayish lesions forming elevated marks. And on fluorescent angiograms, regions of blocked fluorescence in early frames, sometimes with speckled or diffuse hyperfluorescence that fades over time. In late frames, a diffuse ground glass appearance with defined margins can be seen. And then on spectral domain OCT, well-defined homogeneous or heterogeneous regions of abnormal hyperreflectivity distributed between the outer retinal layers, often encompassing the photoreceptor layer and the RPE. These outer retinal layers may be wholly or partially replaced by horizontally oriented bands of hyperreflectivity. So what then we did is looked at what we did, we then nominated OCT as the reference standard, and we then compared the ability to detect fibrosis on NFS modalities like the color fundus images and fluorescent angiograms. And you can see in the first column where we detected fibrosis on OCT, and on the second column, those cases where we did not see evidence of fibrosis on the OCT. And then when you look at the NFS imaging modality, we had 28 cases, but we missed when we graded on the fibrosis, presence of fibrosis on NFS. And there are 13 cases where we graded positive for fibrosis on NFS imaging modality, while there was no evidence of fibrosis on OCT or AGRM that corresponds to fibrosis. So what we wanted to see then to understand this discrepancy, where this discrepancy is coming from. So what we did then, we factored in the location of fibrosis or AGRM in our analysis, and we looked at the sensitivity of detecting fibrosis on NFS imaging. And what you can see here, we have about between 67 to 87 sensitivity when the AGRM was subretinal. When we looked at those cases where the AGRM was sub-RP, or sensitivity on detecting fibrosis on NFS dramatically dropped. Now it's between 15 and 33%. So this might explain the heterogeneity in reporting fibrosis prevalence and incidence in studies that using different imaging modalities. But would this information, further information that we can extract from OCT, like the location of AGRM, important or clinically meaningful in terms of function, in terms of visual acuity? This was our next question. So what we did is we first looked at how the detection of fibrosis, just presence or absence on different imaging modality, can explain BCVA variance in all cohorts. And what you can see here, the R squares are quite low, and it's about between 6 to 9% of BCVA variants cases can be explained BCVA variants. But what happens when we include location information in the model? We can see that our R-square doubled all of a sudden. So that means now we can explain BCVA in about 15% of the cases. And then when we include even more information on the age arm, such as the dimension, our model explains now 30% of the BCVA variants. So that just to summarize our findings, OCT is superior to color fundus and fluorescent angiograms or NFAS imaging modalities for detecting fibrosis, and detection sensitivity of fibrosis is limited on NFAS modalities, and it's highly dependent on the age arm location that can only be extracted from OCT images. And OCT detected age arm explains much better visual acuity when other characteristics of age arm also included in the model. And so we propose that OCT characteristics of age arm should be considered as anatomical endpoints in AMD treatment trials. So OCT should be the new reference standard. And so in terms of future direction, where these results directed to us, it's basically happening now. These are my conflicts for this project. And this is the fibrosis project. And what we set up to do is a deep characterization of AMD imaging features. And we built an amalgamated database. We exported data from the EDNA study, which I was just talking about in terms of the previous project. And we got data from real world data from UK clinics, from Belfast clinics and Nottingham clinics. And we carry out a retrospective reanalysis of data through high-quality detailed manual image grading by the network UK reading centers, namely Belfast and Liverpool. And by doing so, we will be able to identify predictive biomarkers, retinal changes that could be used as predictive biomarkers for patient stratification in treatment trials. We will be able to identify retinal changes that shows the strongest correlation with visual acuity. We will be able to identify retinal changes that shows the strongest correlation with different treatment strategies. And by doing so, we will be able to identify best treatment regimen. And basically, this is a step towards precision medicine. And so what's our data? Sample size is total sample size 550 cases of newly diagnosed AMD. And we will, what about our samplings? After treatment initiation, we get data up to 6 years follow-up visit. And as you probably noticed, we have much more frequent sampling in the first year and a half. And that's because we want to understand retinal changes just after the treatment initiation. We think that's important. So what are these retinal changes we grade for in terms of OCT features of age arm? We just seen that the location and dimension is important. We also want to look at the reflectivity and the definition, whether it's ill-defined or well-defined. In terms of other NAMD features, we will grade for presence of fluid, autoretinal tubulation, pigment epithelial detachment, presence and changes of intraretinal hyperreflective foci. And then in terms of OCT features that associated with macular atrophy, such as changes to the inner plexiform layer, outer nuclear layer, and EZ band, retinal pigment epithelial changes, hypertransmission of OCT signal into the choroid. These are all features that we are recording. And we also grade NFAS imaging, and then correlate results. We grade fibrin, blood, lipid, and pigment on fundus color images, and we grade for disease activity, CNV location, lesion type, and lesion area on fluorescent angiograms. And these are my references. And thank you very much for your attention. Happy to take question.
Thank you so much, Lajos and Tunde. This is really brilliant work, and it really sheds light on a so important feature, as you show, has also high functional impact on these eyes. Maybe before we discuss later, one question to you. What do you expect? Your longitudinal study is up and running. How are the dynamics of fibrosis, and how is the impact of continued anti-VEGF treatment? There's the view of clinicians, one fibrosis, it sits there, it doesn't grow, it doesn't get bigger. What is your view? What is your experience in these patients?
Lajos, do you want to take that, or?
Yeah. So what we think is what you could see. We're gonna do. We focus on the first year and a half. We want to see more frequently the images and changes on the retina, because we think that's where the most of the change will happen. And there are, I mentioned ill-defined and well-defined fibrosis or HRM on OCTs, and ill-defined HRM most likely will disappear over time, and well-defined HRM might stabilize and become fibrotic. I believe. I don't know if Tunde, you want to add to it.
So I think with that's one of the reasons why we also look for atrophy, because the interplay between atrophy and fibrosis is going to be important for the final visual outcome. And we've got very well characterized patients with all of these modalities, so it will be good to look at these in a very organized way, just so we can see how both behaves over time.
Great, fascinating work, and I pass over to Anat to introduce Professor Munk.
Yeah, and we'll have more time for questions. So you presented an amazing, I think, a groundbreaking concept of identifying and following fibrosis by OCT, whereas to me, we were always taught you look at it on color pictures, combining it with a clinical image and the fluorescein angio. So it's really, I think it's very promising. And now we will hear about, okay, so we can see it and diagnose it, but now we will hear about therapeutic strategies against fibrosis in retinal disease from Professor Marion Munk. Marion, take it away.
Thank you so much. Thank you for the kind introduction, and also thank you for the kind invitation. So as you can see, I didn't say therapies against fibrosis. I said therapeutic strategies, because for now, we really do not have a real treatment against fibrosis. Before I start, I really want to emphasize here, I have some financial disclosures which are relevant for this talk. I hold a patent for a drug which is developed by Asana Therapeutics, and I'm also acting CMO there. So you will see some data from these trials. Like I said, and like you've also seen by Lajos and Tunde's presentation, so before we had anti-VEGF, we had a big problem with fibrosis, and we saw these large fibrotic scars. Now, when we treat patients with anti-VEGF, we have significantly less fibrosis, but we still get fibrosis. So even when the patients are well treated and the disease is really under control, the sole treatment of with anti-VEGF alone does not prevent fibrosis and the progressive increase of fibrosis development. And the prevalence of fibrosis is really very much dependent on the MNV subtype. So this was just a recent paper which was published last year, 2025. And what you can really see here is that fibrosis really does not happen later on. You can already see in some subtypes and in the type 2 MNVs, and also in a mixed type, so mixed type 1 and type 2 MNV, that actually the majority of patients already develop fibrosis by 6 months. And then when you follow these patients and these subtypes, you see that after 1 year, the majority of patients, so over 86%, have developed fibrosis. And when you follow them further on, this prevalence rate increases to over 96% after 3 years. However, There is also type 1 and type 3 MNV, and of course, type 1 MNV is the majority of our patients with neovascular AMD. And here you see that actually fibrosis is not such a big issue. So the prevalence rate here and the incidence over the course is much, much lower. You already heard by Lajos that actually the pure definition or saying whether fibrosis is present or absent is quite challenging, and it really depends very much on what image modality you use or whether you combine the different image modalities. But when we have a look at the prevalence rates of fibrosis and we look at the different image modalities and look at all the trials which have been done after the implementation of anti-VEGF, you can really appreciate here that actually 50% when you use a combination, or at least 45% when you use color fundus alone, or SD-OCT alone of 42%, show fibrosis when they're controlled and when they're treated with anti-VEGF. So unfortunately, anti-VEGF, by controlling the disease activity, has significant effect and benefit of fibrosis, but it does not prevent fibrosis completely. But why do we care about fibrosis? So of course we care about fibrosis because it means vision loss. And I think every one of you have seen this kind of 5-year data from the CUT trial, where you compare patients who had atrophy or fibrosis development. And when you compare the patients at baseline, there is a slight difference between the patients who will develop or who have fibrosis and atrophy. And after 1 year, there's also a slight difference. But the mean or the most difference you can really appreciate then down the line. So after 2 years, when you follow these patients up to year 5, you can really see that the visual acuity significantly differs between these two patient populations, whether they develop fibrosis or atrophy compared to the patients who do not. And here also, when you look at the scar formation, so whether the patients had new scar formation from year on, you see significant letter loss of a mean of 20 letters. And the patients who had already developed fibrosis and only showed an increase of the existing scar showed after the 2 years further mean of 10 letter loss. But when we control the activity of the disease, why do we still develop fibrosis? So the thing is that there are multiple causes of fibrosis. So the main hypothesis is the non-inflammatory multi-hit hypothesis. It means that you have one hit in terms of neovascular AMD. You have like the development of exudative neovascular AMD. But even if you get this neovascular AMD under control, there is still chronic continuous degradation and degeneration going on, which can't be controlled just by controlling the activity. So here this continuous fibrosis results from the epithelial injury and abnormal wound healing in the absence of chronic inflammation. Of course, also vascular remodeling plays an important role, which is chronic, and it supports fibrosis and the epithelial to mesenchymal response. Of course, inflammation itself also causes fibrosis, and this is true for acute as well as chronic inflammation. And then we also have autoimmune reaction. So autoimmune reaction per se is also inflammation, but here we know this from uveitis, for example, or also in retinal vascular diseases where we have more inflammation, we get like more fibrosis. But even the autoimmune reaction plays a role here. And I'm particularly interested in this kind of part in terms of molecular mimicry. So far, I've only looked into uveitis, but there's also some preclinical evidence that molecular mimicry and therefore an autoimmune inflammation may also contribute to the continuous degeneration in neovascular AMD. When we have a look at the main hypothesis, so like I said, you have a first hit of acute neovascularization and acute neovascular active AMD. And based on this, you have RPE and endothelial injury and apoptosis, but this continues. And you get continuous loss of basement membrane, and then failure of the re-epithelialization and re-endothelialization. So you can kind of describe this kind of progress as epithelial to mesenchymal transformation, which also means that the RPE cells, which are epithelial cells and are very, very specialized, they slowly degrade into mesenchymal cells, and then of course do not have the function anymore. They are just scarring scales and mesenchymal cells. And based on this, you get fibroblast proliferation, you get extracellular matrix deposition, and then you get, in addition, a release of profibrotic growth factors. And here, the main leading growth factor is TGF-beta, but also other factors like PDGF or insulin-like growth factor. One plays a major role here in terms of contributing to this kind of cycle. And then, of course, if you have these profibrotic factors here, you get more and more fibrosis. So you get continuous increase in fibrosis. Where are the therapeutic strategies? So actually, you've seen kind of these multiple ways or multiple causes of fibrosis, and actually there in every single step you can really intervene and use potential drugs here. Of course, you can try to inhibit or decrease inflammation by decreasing reactive oxygens, by inhibiting cytokines, and also by inhibiting kinases, like for example the tyrosine kinase inhibitors. You can also try to promote epithelial restoration by mitogenes and stem cell progenitors. But of course, you can also try to limit the aberrant vascular remodeling by inhibiting the angiogenesis. You can increase the host defense by interfering with interferons and prostaglandins. And then, of course, last but not least, you can try to inhibit the fibroproliferation by inhibiting these certain growth factors and chemokines. Like I previously said, VEGF has been shown to significantly reduce fibrosis. And we know from a lot of retrospective studies, for example, here from the retinal find blindness study, that if patients are insufficiently treated, they are more prone to fibrosis, while patients who are overtreated are more prone to atrophy. And so the first thing and the best thing you can do nowadays is really to treat the patients adequately, especially these certain subtypes who are more prone to fibrosis, to really try to prevent the fibrosis development. Another targets which are currently under development and under consideration are tyrosine kinase inhibitors. Tyrosine kinase inhibitors are actually inhibitors which inhibit the phosphorylation of the tyrosine kinases of tyrosine kinase receptors. And actually a lot of different receptors which are very important in the eye are tyrosine kinase receptors. So for example, VEGF receptors are tyrosine kinase receptors. So, and if you inhibit the phosphorylation, you also inhibit the activation. Nonetheless, different tyrosine kinase inhibitors have different, a little bit of different mode of action. So they can be more potent in inhibiting some receptors than the others. And this is also why the different tyrosine kinase inhibitors, which are currently under development, have different potential in terms of inhibiting fibrosis. This is just a table of different tyrosine kinase inhibitors which are currently under development or are already on the market, but not for eye diseases, but for other diseases. And here you can appreciate their potential antifibrotic strength. So for example, nintedanib seems to have a strong antifibrotic strength, while for example axitinib, which is the current drug from Ocular Therapeutics in phase 3, seems to have a more weaker antifibrotic strength. Also, sunitinib, I think this is an TKI inhibitor developed by Panoptica, seems to have a moderate antifibrotic strength. But Like I said, it may be that they have very strong anti-angiogenic properties, but they differ in terms of the antifibrotic strengths. In terms of antifibrotic strength, I think the TKI of nintedanib, which is currently in preclinical development, seems to have the most potency in terms of antifibrotic agent. So actually, this kind of tyrosine kinase inhibitor is already in the market, but not for eye diseases, but for pulmonary fibrosis. It's already used. However, Boehringer has started to look at it in terms of the preclinical development also in eye diseases. And when they had a look at CNV models, they saw that the injection intravitreally of this drug lead to a reduction of fibrosis and neovascularization in the laser CNV model. And they also saw that when you stimulated human RPE19 cells, so these kind of cell lines with TGF-beta 2, which is a main promoter, and then used the drug, they showed that they could normalize the EMT, so the epithelial to mesenchymal transformation signature, and also normalize the RPE phenotype. So it meant that the RPE cells didn't develop into mesenchymal cells, but kept their main phenotype in terms of polarized epithelial cells. Another drug with a potential antifibrotic property is faricimab. However, I have to emphasize here that the phase 3 trials, none of the predefined endpoint showed any benefit in terms of fibrosis. So fibrosis was not a kind of predefined endpoint for this drug, but they've shown in preclinical studies that if you treat, for example, a CNV mouse with combination of VEGF-A and Ang2 inhibition, you see a reduction in fibronectin, which is an important marker for fibrosis development. What is also interesting is if you try to kind of inhibit the fibronectin development or the detection with VEGF-A alone or with Ang2 alone, you don't see any effect. So there seems to be like, if there is a potential antifibrotic effect there, it seems to be by the dual inhibition of VEGF-A and Ang2 here. Another target, of course, is TGF-beta 2 because it's the core driver of epithelial to mesenchymal transformation and the fibrosis development. And at ESANA, we are developing oligonucleotide antisense against TGF-beta 2, which means it's actually a drug which inhibits or which binds to mesenchyma to the messenger RNA of TGF-beta 2 and therefore inhibits the TGF-2 production. We've seen in preclinical models that there's a dose-dependent response here, and we see a dose-dependent reduction of fibrosis development in CNV models, and we see also a long-lasting durability of up to 4 months. Of course, preclinical models and animal models are not humans, and so what we saw in the first phase 2A trial, where we injected this kind of TGF-beta antisense, is that we saw a reduction in central retinal thickness similar to anti-VEGF, and this is due to the downstream effect of TGF-beta. But what is more important is that we saw a reduction of fibrosis volume, which was consistent to fibrosis in the color fundus images, while in the standard of care treated eyes, we saw an increase in the fibrosis volume. So this is just a representative example of a patient under ISTH 0036, where you see not only the reduction of fluid, but also a reduction in the fibrosis volume and significant improvement of visual acuity. So overall, to summarize, I think targeting fibrosis and really bringing a drug to the market against fibrosis is really still something which is very well needed, not only in neovascular AMD, but really also in other diseases, not only in the retina, also in all kind of eye diseases which deal with fibrosis. Thank you.
Thank you very much, Marion. That was excellent. We don't have a lot of time for questions, but we do have a lot of questions from the audience. So because you finished, let me give you the first question from Vijaya. Between overtreatment and undertreatment, therefore risk of atrophy versus scarring, is there any way during the course of treatment to identify the boundary? If you can, a very short answer so that we can get to other questions from the audience.
I think if you're not sure, rather overtreat than undertreat, because the direct correlation between overtreatment and macular atrophy has not been shown as good as the direct correlation of undertreatment and fibrosis.
Okay, and we have a question to Rosa about the PDS. Should patients be pseudophakic before implantation?
No need. No, could be phakic or pseudophakic, both.
Okay, and that was from Arthur Zemitis, and we have from Mol a reservation. They cannot imagine medical retina doctors using this in the theater. So is it just for surgical retina specialists, in your opinion?
Well, I mean, you need to put the cannula for fluid. It's true that no need of vitreoretina surgery per se in the procedure, but it's true that if you have a complication, then you need to have skills. So I will suggest, either doing SPR or at least team up with a BR surgeon.
Okay, Frank, I'm passing to you.
Yeah, thank you. If I may ask to Marion and Rosa, so with the PDS and the continuous delivery of agents in the eye, it's different, no seesaw pattern or anything. Do you expect less or more fibrosis? What's your guesstimate, Rosa?
Well, I don't think you can have really less fibrosis because we've seen, I mean, you are targeting only BGF right now. It's true that maybe with a platform and like combining drugs, it's really interesting for me in the future. But maybe we see less if it's better control. But normally frequent, so patients that require frequent injections are type 1. And normally they don't have fibrosis. So I don't think it's really targeting that field.
Thank you. Brief response from Marion.
Yeah, I agree. I think like continuous control of the disease will definitely decrease fibrosis. Maybe not the prevalence, but definitely like the amount of fibrosis in the eye and maybe also the impact on visual function. Yeah.
Right. So if you do clinical studies, you need a robust, validated endpoint in terms of fibrosis measurements and quantitation. Question to Tunde, Lajos, and also Marion, how do you see this technologies, imaging technology fit to have this as a clinical endpoint accepted by the regulators?
Tunde, so if I say it first, because I don't have a drug, so then Marion, as a CMO, can talk. So I think one of them is that we need to have very good functional endpoints that we can prove that they correlate very well with the anatomical endpoint, and that it matters to the patients, because we see that with regulators that it does have to, endpoints have to matter to the patients. And then we need to be able to use it on systems that we do. So, for example, sort of turning towards OCT will make it much more manageable than doing, for example, fluoresceins for every patient.
Mm-hmm. Marion?
I think for me, it's like hot information because I'm coming from a call 3 days ago from the FDA. So there's so far, we are far away from fibrosis as an endpoint. However, of course, if you're not developing fibrosis, you also have like better visual acuity. So via this kind of way, it's definitely possible to kind of establish these kind of drugs. But I think Tunde and Lajos, you will have to put a lot of work into that to establish fibrosis as an endpoint. And please do
what
so.
And so fibrosis, yes, no is a no-brainer. But what's the minimal cutoff size when you say it's absent or present?
I think that all needs to be worked out in the last 45 seconds.
Starting tomorrow. Excellent. I pass over to Anat again.
Yeah, so a few more questions from the audience. Rosa, real fast answer, quick answers so that we get to everything. Did you inject vitrectomized eyes? Is there any difference in the procedure?
I have no experience.
Yeah, I don't think there should be a big difference, but
Yeah, I suppose, but I have no experience. Yeah.
yeah. Risk of PDS, including risk for retinal detachment, two separate questions.
Yeah, so risks are vitreous hemorrhage, also conjunctiva related, so exposure of the device. Retinal detachment, I think there are some cases, like one in Pagoda that I can remember, but I don't remember the exact number, but it's really low. And also, well, some cases of endophthalmitis. Yeah, but I mean, really low. Yeah. And they have decreased over time with this review of videos and changes in the details.
Okay, Marion, now you have 5 questions for you. For each of them, give like one sentence. Do you agree that the breach of RP by the CNV is the key factor on developing fibrosis?
Yes.
Oh, okay, that was a short answer.
Yeah, right. So,
Naturally.
yeah, it's like the main thing is like injury of the RPE causing epithelial to mesenchymal transformation. Yeah.
Great. What about MMP and their activation in the progression of fibrosis? A question from Arthur Zemitis.
One more time, can you repeat that question? So I didn't.
What about MMP and their activation in the progression of fibrosis?
Yes, definitely. MMP is like important in inflammation, and inflammation causes fibrosis. So definitely also plays a role there. Yeah.
If there is fibrosis, should we continue with anti-VEGF?
Yes, definitely, because otherwise you get more fibrosis.
Do you have any drug as your first option in this situation?
Like I said, there's some preclinical evidence that a combination of inhibition of Ang2 and VEGF-A has antifibrotic properties, but this is not proven like in any trials. So I really don't have like a first of choice drug. Yeah.
Will you inject both anti-VEGF and tyrosine kinase inhibitors simultaneously or alternating?
Probably alternating, because I mean, for the tyrosine kinase inhibitor, you will inject like every 6 months as a kind of basic therapy, and then I would kind of inject anti-VEGFs as a kind of acute therapy. So I would kind of, yeah.
Okay, you already answered the question about between overtreatment and undertreatment, the risk of atrophy versus scarring. Okay, predictors for fibrosis apart from CNV type. We are almost done.
Predictors for fibrosis is definitely hyperreflective material. So not only subretinal hyperreflective material, but also sub-RPE hyperreflective material. They only have different impacts on the visual function. And of course, not only hyperreflective material at baseline, but especially if you inject one anti-VEGF injection or 2 anti-VEGF injection, and you don't see a resolution of the hyperreflective material. So you can be this is quite a good indicator that the patient will develop fibrosis.
Yeah. Did you have to remove the PDS?
I feel like on a hot seat. Now it's your turn.
Rosa.
If needed, you can remove the
Rosa, of course.
Yeah, if needed, could be removed. I mean, there have been cases, but also you can exchange one PDS because of some complication, and then put another one. Yeah, but it will be like a closure of injury in the sclera.
Yeah. So for the question about vitrectomized eyes, the reason that Rosa doesn't have any experience is because it was excluded from the studies, and we'll gain this experience when we'll get to real world use of this promising device.
You said short, so I didn't, but it's true that it's important to take into account because we know the pharmacokinetics are different. So it's a really interesting question, but yeah, so we should really learn.
Okay,
Rosa,
last-
question to you: the degree of liquefied vitreous, is this impacting? Obviously, the leakage will be impacted
Yeah, I mean, but you see
during
that
surgery.
yeah, some vitreous is going out, but you don't see really a big amount, so just a little bit. And you can also use the cutter around, but normally it's not really needed. So you don't have to do any vitrectomy per se.
Thank you.
And last question is, will the webinar will be available on demand? And yes, it will be available on demand under resources on EURETINA.org by the end of the week. Frank, will you please conclude?
Well, I do the pre-conclusion, but thank you so much. This has been really brilliant talks, great discussion, absolutely fantastic. And we reconvene the latest September 4 to 7 at the EURETINA meeting, where we meet our president, Professor Anat Loewenstein, and therefore I give you the concluding remark, Anat.
Thank you very much, everyone. Really, thank you, first of all, Frank, for building this amazing agenda with the newest things that have to do with the CNV. Thanks a lot. And thank you, Marion, Tunde, Lajos, Rosa, for the excellent talks. And thank you the audience for listening to us and for the vivid questions. Have a nice rest of your evening or morning, wherever you are in the world. Bye.
Thank you so much.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye-bye.
Bye-bye.
Bye.